Good morning, everyone. Welcome to NICU Journal Club. I'm Nyaz Ali. I'm going to present today the title of my article that I picked for today is Effect of Enteral Lipid Supplement on Severe Retinopathy of Prematurity. It is a randomized clinical trial. And I wanted to thank Dr. Hogan for helping me and reviewing my slide. And of course, I don't have any disclosure. All right, so here's the objectives for today. Today I'm going to use the PICO-TT format to evaluate a specific clinical question. I will talk briefly about retinopathy of prematurity and will review randomized clinical trial study design just briefly, and then we'll appraise the article. All right, so what was the name of the study? The name of the study was Mega trial. It was a randomized clinical trial that has been performed at 3 university hospitals in Sweden from December 2016 to December 2019. So they include 209 infants. They were born at less than 27 weeks gestation. They assess those infants for eligibility, and then they end up with 206 infants. They did their statistical analysis from February to April 2020. So the article was published online in February 2021 at JAMA Pediatrics. So just a quick review of retinopathy of prematurity. So what is that? It's a disease that affects immature vasculature of the retina in the eyes of premature babies. The exact pathology is unknown, but it believes due to when there is hypoxemia or ischemia of the retina that leads to production of vascular endothelial growth factor, which triggers abnormal vascularization in the retina. So ROP affects 50% of babies when they're born less than 1.2 kg, and only 10% will develop severe ROP. Like any other disease, there is risk factor associated with ROP. So basically, those babies born less than 32 weeks, babies with less than 1.5 kg, IUGR babies, babies who are on oxygen, who have hypoxemia, hypercarbia, or if they have any concurrent illness. So why it's important to monitor for ROP? Because there is a correlation with reduced brain volumes and poor psychomotor development. So ROP classified or categorized in zones and stages to show the severity of the disease. The more severe the disease when it involves the central zone and it has advanced stages. All right, so we have this picture that shows the zones and the stages of ROP. As you see from the picture on the left, stage 1, you see only thin line, thin demarcation line between the vascular and avascular area. And then stage 4, you have partial retinal detachment. I don't have stage 5 on the picture. On stage 5, you will have full detachment of the retina. While the zone, you have zone 1, zone 2, and zone 3. So zone 1 is close to the, which is central zone, it's close to the optic nerve, while the zone 2 and zone 3, they are more peripherally. All right, so what is with the lipids and ROP development? So as we know, preterm babies, they miss third trimester, and that third trimester is really important. Most of the lipids, like long-chain polyunsaturated fatty acid, will transfer from mom to the babies during third trimester. So those long chain and polyunsaturated fatty acid includes arachidonic acid and docosahexaenoic acid, or DHA. And those fatty acids are really important for the structure of the retina and brain. Deficiency of these fatty acid associated with vascular complication of preterm birth. All right, so what is the treatment options for RP? So in terms of treatments, you have a couple of options. You have laser therapy and medical therapy by using anti-vascular endothelial growth factor therapy. In terms of laser therapy, you have to put the babies under general anesthesia, while anti-vascular endothelial growth factor, it affects the other growing tissue, other healthy tissue. So that's why it's important not only to monitor for ROP, always to also to avoid those harmful treatment. All right, so back to our articles. We're going to use PICO format to evaluate the clinical question. The population that they pick, infants born before 28 weeks, and then the intervention that they did, supplementation with enteral oils, arachidonic acid, they picked the dose 100 milligram per kg per day, and DHA, the dose was 50 mg per kg per day. They give it within 3 days of birth until 40 weeks post-menstrual age. And so the comparison was no supplementation, so there was no placebo. The outcome was supplementation with AA and DHA reduced severe ROP in extremely preterm infants. And the type of the question was therapeutic, and the type of the study was randomized clinical trial. All right, just a brief review on randomized clinical trial. So it considered gold standard of evidence. This type of study aimed to reduce biases and control confounding factors. It's a type of prospective studies. So you have to randomize the participant into groups, either to receive intervention or no intervention, and they blind the participant and the researcher to reduce bias. So how did they measure the primary outcomes? By measuring the incidence of severe ROP. The primary outcome, as I said, was incidence of the severe ROP stage 3 or type 1 ROP according to the international ROP classification. While the secondary outcome was measuring the serum fatty acid, bronchopulmonary dysplasia, IVH, PDA, NEC, and they measure safety and tolerance, they measure death and growth. So they measured all those parameters up to 40 weeks post-menstrual gestational age. So they took only 0.6 ml of the blood or serum to check for phospholipid fatty acid, and they check it at birth, and then day 3, day 7, 14, and then they checked it bi-weekly. So in terms of inclusion criteria, as I said, they include babies born before 28 weeks, and they were very specific about the target range for oxygen supplementation and oxygen saturation. So they include babies with SATs of 91 to 95 if they were on any oxygen therapy. In terms of exclusion criteria, they exclude infants that were born before 28 with any clinical growth malformation, if they have any syndromes or chromosomal abnormality. They exclude babies with neuropathy, retinopathy, nephropathy. They exclude babies with micro or macrovascular disease. that needed treatment. They also exclude any babies with condition that may interfere with the result or maybe put them at risk for non-compliance. All right, so this table, it shows how they include their babies and how they search for eligibility. So as you see, so they started with 209. They exclude 2 because they did not meet the criteria. And then they end up with 200. They randomized the 207 into treatment group and control group. So they picked 102 for the treatment and 105 for the control group. So they analyzed the result or the data by using different statistical analysis method. They use intention to treatment analysis. So basically, what that method is, whenever you randomize a participant, you have to analyze the result no matter what, even if they lost follow-up, even if they are not compliant with the treatment or the intervention. So they use that method in randomized clinical trial to avoid differences between the treatment and the control group. So they wanted to keep the integrity between the two groups. So they also use, they analyze in safety population to monitor for safety of the intervention. All right. So sorry about that. This is a busy table. So it shows us how did they randomize their participants. So as you see, if you start from the left, in the treatment group, they picked less babies born less than 25. They picked less number in the treatment group than the control group. And they include babies, more bigger babies or older. So they include more babies born more than 27 weeks. And as you see, in the treatment group, they picked babies that's heavier in the treatment group than the control group. And they include more single babies than twin babies. As we all know, singleton, they have better outcome than twin babies. Oh. Sorry about that. All right, so how did they do their randomization and how did they collect the data? So the neonatologists or the research nurses, they assess the infant for eligibility, and then they give the written informed consent to the guardian, and then randomly assign to either treatment group or control group by using a computer generator. So the randomization was stratified into 3 groups, or according to the gestational age. Group 1, they were less than 25 weeks. Group 2, 25 to 26 weeks. And group 3, 27 weeks. So the ophthalmologists, they were blinded to the randomization, but the neonatologists, they were not. While the people who measured the serum phospholipid, they were blinded to randomization as well. Right. So what was their trial intervention? As I mentioned before, so they supplement with AA and DHA. They picked the ratio 2:1. So they extract those material from fungi, and they extract DHA from alga. So the emulsion that they picked the dose was 0.39 ml per kg per day, and that was given enterally within 3 days after birth. So the dose that they picked, a dose was 100 milligram, while the DHS was 50 milligram per kg per day. So what was the result? So the result was treatment with AA and DHA reduced the severe ROP compared with the standard of care. So only 16 out of 101 in the treatment groups developed severe ROP, which is 15.8%, while the control group, they 35 out of 105, which is 33.3%, developed ROP. The adjusted relative risk was 0.5. They used confidence interval of 95%, and the range was between 0.2 to 0.9, which is not wide, and the p-value was 0.02, which is statistically significant. So that's for the primary outcome. While the secondary outcome, so AA and DHA group had significantly higher fractions of AA and DHA in the serum phospholipid compared to control group. So the main difference in the treatment group was 0.8 mole % with confidence interval of 95 and the range 0.4 to 1.5, which is a wide range, and p-value was 0.001, which is statistically significant. While the treatment group, so was the main difference was 0.13 mole % with confidence intervals of 95, and the range was 0.01 to 0.24, which is a wide range, and p-value 0.03, which is statistically significant as well. All right, so this table shows the outcomes, the primary and secondary outcome. So we talked about that, and then if you look at the bronchopulmonary dysplasia on secondary outcome, in the treatment group, 48% they develop PPD, while in the control group only 48. So it's similar, and the p-value is not significant, was 0.6. In terms of IVH, let's see. So we could look at grade 3 and grade 4. Only 6 patients developed grade 3 in the treatment group, while 4 patients in the control group. PDA was more on the treatment group, and comparing to the control group. All right. So there were no significant differences between the treatment and control group in the following bronchopulmonary dysplasia. As I mentioned before, IVH, no significant differences as well. Well, in terms of sepsis, it happens in 42 patients out of 101 in the treatment group versus 53 in the control group. And serious adverse events happens in 26 patient of 101 in the treatment group versus 26 in the control group. While death happens more, the rate was more in the treatment group, 15.8 comparing to 12.3% in the control group. All right, so what was their study conclusion? The study conclusion, supplementing the diet of immature infants born at less than 28 weeks with enteral lipids with AA to DHA ratio of 2 to 1 had no significant adverse effects, and it looks like it's a promising intervention to prevent ROP and not only reduce visual changes and blindness, but also exposure to harmful All right, so let's appraise the article. So to appraise the article, we have to ask ourselves certain questions. Are those the result of the study valid? What are the results? Can this result help taking care of my patients? All right, so are the results of the study valid? So we have to ask ourselves a few questions. Did the trial address a clearly focused issue? They did. So they were very specific on effects of supplementing with those fatty acid and effects on developing RP. Did they assign the patients to treatment randomly? They did. They randomized the patients and participants. And then were the patients or the health worker blinded to the intervention? So the neonatologists, they were not blinded and the patient were not blinded, but the ophthalmologists and the people who were measuring the serum level of fatty acid, they were blinded to the intervention. Were the groups similar at the beginning of the trial? They were similar. And were the group treated equally? They were treated equally. But as you remember, they included babies in the treatment group. They were older and heavier. All right, so what are the results and how large was the result? So they measured the primary and secondary outcome, and they had results for both of the outcomes. For the primary, they measured the incidence of severe RP, and for the secondary outcome, they measured the level and the other factors like developing PBD, IVH, PDA, and other factors as well. All right, so this table tells us the primary outcome. It shows us the primary outcome. As you see, the primary outcome, RP, developed less in the treatment group compared to the control group. And this table shows us the secondary outcome. As you see, the level of AA and DHA is more in the treatment group than the control group. All right, so how precise were those results? So the results were precise. The primary outcome has significantly decreased the percent from 33.3 to 15.8, almost half. And they adjusted the relative risk was 0.5, and they had narrow confidence interval. Can I apply the result of the study in taking care of my patient? So are those the trial, are those the patient population in the trial, are they similar to my patient population? Yes and no. So the patients in NICU, generally they have similar needs and issues, but they were very specific in their SAS ratio and range. I think here is different than, our guideline is different than their guideline. We use less parameter, but we may be able to apply the result of their study for certain points. So were all clinically important outcome considers? Yes, they included primary and secondary outcome. They also included possible adverse events. So what was the limitation of this study? They did not have placebo, and the treatment was not masked to the caregiver. But as I mentioned, the ophthalmologists and the people who were measuring the fatty acid level, they were blinded, and they were not very specific about the ingredient in the oil other than the AA and DHA, which also may affect the results. So what was the strength of the study? So the study included multi-center design. They randomized the participant to treatment and control group, and they divided into gestational age stratification. They picked 3 gestational age group. But overall, the study looks promising intervention to prevent RP and reduce harmful therapies for severe RPs. In terms of future study, we need to focus more on optimal composition of the fatty acid for preterm infants that are born at different stages of development. We want to know exactly how much those babies, how much fatty acid they needed to avoid ROP. And the goal should be to identify the fatty acid composition that result in the best health outcome. Here is my reference. And now if you have any question, you could type in the chat box or you can unmute yourself.
Okay.
Sure.
I don't know if people can hear me without unmuting. But
You could use.
one of the things I have to say is I want to see if they compare to our population. So the other night I went through, they had in their control group a 33% incidence of severe ROP. In the same time frame, I looked up our babies on baby step reports, and we had 7% severe ROP versus their 33% ROP. So I wonder how much of a benefit we would get from this. Just mentioning this, it's also interesting that in their control group, 12.3% died. At the same point, we had 26% death. So they had a combined severe ROP plus death of about 46%, and we had a severe ROP or death of 33%. I'm just talking about their control group. So for some reason, our babies die more, but don't get ROP. One thing that I noticed, I didn't do a deep dive, but they did fix how many babies from each gestational age category. So they had 76 babies in the less than 25-week group, and we only had 45 babies because we weren't controlling for anything. So we had 45 babies. More of our babies, I happened to notice that a lot of the babies who died in that group were 22-weekers. They did have 22-weekers. I did not do a mean gestational age, so I can't tell how much our death was impacted by our number of 22-weekers. So that's just information. I think the big thing for me was that they had in their control group, they had a 33% severe ROP rate, and we only have 7%. So I really have to question how much of an effect this would have on our practice.
Dr. Ward, the sepsis was an interesting thing of how there was a difference there. And I'd sent you an email about that because that's one confounder that it doesn't look like they statistically analyzed, and that could be affecting how they randomize the patients, that there's a random error potential if they didn't use that confounder and consider that. But I thought this was an interesting study. I thought it would be easy to do a placebo, and it sounds like that more work is going to be done to where they try to do that. But it's interesting. I'm curious if the neonatologists have adopted this, or is it kind of region specific if this is a considered treatment already?
We haven't heard. I mean, we're not using it.
No.
And I hadn't really heard it in the literature either.
And then if you look at the levels, maybe I'm looking at it wrong, but I wasn't impressed with I think it's maybe figure 2 that you showed, that there was much of a difference really between the levels. And then it comes into question, are the children really even absorbing it? Or did they just, based on how they sampled the population, did they just tease out something that's not really there, that there is no benefit?
And whenever we're giving something orally early on, we worry about necrotizing enterocolitis. They didn't find a difference in that, but it's always a concern.
Yeah, it looks like with the one you have there, the confidence intervals seem pretty wide if that's what they're going for with the spread. To me, it looks very similar. Those levels look very similar. And then they did one where they showed the intention to treat analysis with, yeah, that one. If you look at the bottom there, you see their levels, the AHA and the DHA levels compared to the control, and it looks pretty similar across.
Where you are. But Nick Johnson does make a DHA, ARA supplement. And of course, you know, they will promote it for brain development and, you know, even beyond the ROP. And I have been thinking about presenting it as an option for those babies that we have on long-term TPN and lipid restrictions, simply because they do not meet the recommended DHA and AA intakes.
Okay.
All right. If you don't have any question, that's it for today. Thanks for joining us and have a nice day.